Welcome to the second part of the heart failure pharmacotherapy. And in this part, we will talk in details about the clinical benefit and therapeutic consideration for the pharmacotherapeutic choices in heart failure, mainly with reduced ejection fraction. The first agents to cover is diuretics. And diuretics, of course, indicated mainly in patients with evidence of fluid retention, and it has a wide range of benefits that can be offered on short-term, intermediate, and long-term, but it is important to highlight that diuretic therapy has no mortality benefit in patients with heart failure. With regard to the therapeutic consideration, of course, when we talk about diuretic and heart failure, we talk mainly about loop diuretics with respect to the higher diuretic capabilities and also its ability to retain efficacy with reduced renal function. The bioavailability consideration when converting between oral and IV agent is very important. 50% difference is there. So it is very important to consider this one while converting. The impact of diuretic on the electrolyte and maintaining the balance through monitoring and maybe keeping eye on the potassium and magnesium level is needed. Monitoring of the renal function to assure the balance and to avoid the overdiuresis and the resulting AKI that can be there also is one of the main important therapeutic consideration while maintaining or giving the patient diuretic therapy. Coming to the target, what actually we target in terms of the decreasing the body weight or decreasing the fluid accumulation, this congestion, the target is between 0.5 to 1 kg decrease in body weight per day if the patient is already overloaded, and less than 0.5 in case of maybe the diuretic resistance and inadequate diuretic dose that has been given. In general, we can say no difference between the continuous infusion or the bolus dosing of furosemide with regard to the mortality, the length of hospital stay, and the electrolyte disturbance, almost the same. But it is also important to highlight that the continuous infusion in terms of maybe the effectiveness or the effect of diuretic and the safety profile and the reduction in the pre-natriuretic peptide, all this were in favor of the continuous infusion. And that's why, if you notice back in the first part, when we talk about the second stage in treating acute heart failure, we highlighted the continuous infusion. This just a table what actually the agents available, the loop diuretics. We have furosemide, bumetanide. We have cyanide diuretic that can be add on maybe in the issue of the diuretic resistance. One of the strategy to add one diuretic with a different mechanism, like the cyanide diuretics, to help to have the synergistic effect on the total diuresis in a given case. And the third type of the third class of diuretics will be discussed later, the mineralocorticoid antagonist. So the second therapeutic agent that deemed to be very important in patients with heart failure is ACE inhibitor or ARPs. Okay, in the first place, it is important to highlight this a mortality benefit medication, means it has impact on improving survival, improving quality of life in all classes of heart failure. And that's why we say this integral part of the care of patients with heart failure. And there is no much interdifferences between different agents, between the ACE inhibitor, in terms of their impact on the symptoms or the survival. This actually a very important point, because most of the time in therapeutics we used to highlight the class effect or the drug or the agent effect. This seems to be class effect. The ARPs, the angiotensin receptor blocker, is also indicated to replace the ACE if issue of intolerance is there. And in general, there's no much difference between the ACE and ARBs in terms of the cardiovascular outcome, the mortality, and the hospitalization. Some claims, of course, recommend the ARBs sometimes of better claims to be better side effect profile in terms of the incidence of cough and angioedema. One of the issues is the patient can be a heart failure patient, chronic heart failure, and then develop acute heart failure. And if you remember, in acute heart failure, we don't have ACE in acute heart failure. So what if the patient is a chronic case receiving ACE inhibitor and then develop acute decompensation? What should be done in this case? So if the patient already receiving means he's already receiving prentopril, for example, just stop. It's advised to stop at least 24 hours in case the PP is quite low, 100 ampere. And you can recommence at a lower dose once the PP is stable. Sometimes you wait until the PP cross the 120. You may also refill to the same dose before the acute exacerbation. Monitoring serum creatinine and potassium is very important. It is well known that the ACE inhibitor is contributing to the hyperkalemia, and the ACE inhibitor has some impact on the renal function. So a monitoring of both parameters is very important, especially in patients at a bit higher risk to develop this electrolyte or renal function disturbances, like patients with already hypertension and DM patient and patient receiving some other potassium supplement or agents that can contribute to increase the serum potassium levels. One important point, is there any much difference between the ACE and ARBs in terms of the impact on the potassium level or the renal function or the hypertension? No much difference. What about the ACE intolerance? ACE intolerance mainly will be contributed in most of the cases maybe by cough or angioedema, and those patients can be benefited of consideration to switch to ARB. But one also important point, that the ARB is not a class with 0% of cough or angioedema, and actually the incidence is different between different agents. So even the safety profile, you can still investigate the incidence of this side effect with individual ARB agents before choosing the agent to switch to. Here, just maybe a table for the available ACE and ARBs agents with their initial dosing and target dosing. The third therapeutic class is beta blocker. One of the very important medication for heart failure that almost all patients with heart failure with reduced ejection fraction should be on beta blocker. Actually, in terms of the clinical benefit, of course, it has impact on the mortality and hospitalization, but it is good to know this. The evidence comes from trial add on the beta blocker to ACE inhibitor. Okay, so when added to ACE inhibitor, they show 35% maybe decreased mortality, 25 hospitalization as a relative risk reduction compared, of course, to the placebo. Also, it has been stated in so many references that initiating therapy with a beta blocker first is not inferior than the standard approach of starting with ACE. Which one to give first? Some data, it is not that inferior to start with beta blocker and then, of course, add ACE. Here, we are not comparing head-to-head comparison beta blocker or ACE, but which one to start first? Is it really matter or not? So some data say it is not non-inferior, but again, it is good to highlight that the clinical beta blocker add on to the ACE inhibitor. Okay, as mentioned earlier, in acute cases, what actually the situation with the beta blocker? So beta blocker is better to be offered when the patient is a bit stable, euvolemic, no volume overload, not overloaded. So it has to be added on to the ACE inhibitor when the patient is a bit stable and it is no longer euvolemic. So in acute heart failure, uh, it is not that recommended to initiate beta blocker in the acute decompensation. In terms of caution and contraindication, there are so many, but we highlighted the common one. Of course, the bronchial asthma and the symptomatic bradycardia, hypertension. And in bronchial asthma also, it is common to hear from our student that contraindicated in any patient with asthma. Here, actually, it depends. It depends because some reference say if the asthma or the respiratory condition is maybe a bit uncontrolled and the exacerbation is to some extent frequent, in this case, beta blocker might complicate the issue, but not labeling the bronchial asthma as a contraindication, it is not that accurate. Monitoring, of course, the BP, the heart rate, and symptoms of maybe hypertension or bradycardia is very important. In terms of dosing, okay, in ACE inhibitor, for example, the dose, even lower doses, is associated by almost similar impact on the mortality or the survival, the mortality benefit. In beta blocker, it has been noticed that the higher doses are associated with a greater impact in terms of mortality reduction. So, suppose the patient has ACE inhibitor, beta blocker, and some other cardiac medication. Okay, so we considering that the higher doses of beta blocker, higher mortality benefit may guide us to manipulate or play with the doses of other medication, other cardiac medication first before coming to the beta blocker. For example, maybe reduce ACE inhibitor first before coming to reduce beta blocker. This might be an interesting point. Here, in heart failure, is also good to know that the evidence coming from the clinical trials support for agents. It is not all the class support for agents to be used in heart failure. Of course, I think the carvedilol may be the common one or the classical one, the dilatrend. Also bisoprolol, metoprolol, and nebivolol. And nebivolol, of course, it is the newest one, and it is a bit unique because besides being a high selective beta 1 blocker, it has also some what you call endothelium derived vasodilating effect modulated by the nitric oxide. It is quite unique among the other beta blocker in that sense. The third therapeutic class is the class of the mineralocorticoid receptor antagonist, which has maybe two main agents have been tried in patients with heart failure, either the severe heart failure or mild heart failure. Severe heart failure is spironolactone, reducing mortality and rehospitalization when adding on top of the current medication of ACE, loop diuretic, and digoxin. The eplerenone has also shown some benefit when adding to a beta blocker and ACE inhibitor in patients with mild heart failure. In general, in this class, the renal impairment or keeping eye on the kidney is very important, especially in patients with acute decompensation or acute dehydrating illness. In this case, monitoring closer one could be warranted. When it comes to the therapeutic consideration, of course, the renal function and potassium levels are very important, especially in patients, the high-risk group, as we highlighted earlier, diabetes, pre-existing renal problem, or older age. Because it's potassium-sparing diuretic, so no need to give extra supplemental potassium if the patient already receiving the MRA in absence of hypokalemia. And sometimes if the potassium highlight or cross the 5.5, you have to think about maybe decreasing 50% or sometimes discontinue the medication for a while. It is also maybe commonly reported in patients with spironolactone, the gynecomastia or the enlargement of the breast in men was reported 10% in randomized control trial. And this one is not that reported with epinol, which is why can be considered as a good alternative in this case. So now, what else we have in the pharmacotherapy of heart failure on top of the 4 choices, the classical one we have discussed? We have also a relatively newer agent, the secupetal valsartan, the angiotensin receptor neprilysin inhibitor, the avapridine, the nitrate, and of course the digoxin in some cases. Let's take some notes about each one of them. So the first of the relatively newer agents is secupetal valsartan, or the angiotensin receptor neprilysin inhibitor. And this agent is quite unique because the recommendation is toward replacing the ACE and ARBs in patients with heart failure reduced ejection fraction remain symptomatic. And for this replacement, it shows impact on mortality, hospitalization, and the overall heart failure symptoms. And this maybe relatively privilege over the ACE inhibitor was consistent, regardless with the patient how optimized the background maybe therapy, the patient undergoing coronary vascularization or not, the dose of beta blocker used that we have highlighted. All these category of patients, the secupetal valsartan shows maybe more privilege as a replacement therapy for patients who are tolerating ACE and ARB. So coming to the practical therapeutic consideration. So as a replacement, so one question. Okay, how we can shift or switch from ACE inhibitor to ARNI, the secupetal valsartan. So to switch from an ACE inhibitor, you need a washout period of 36 hours to decrease the additional risk of angioedema. Okay, the next question, whether this washout period is also needed with ARP or not. So this is quite different because in with ARP, the no washout period is recommended. The drug actually was found also, maybe to some extent you can link to the beta blocker one, that the benefit is much more a dose dependent or dose related. So titration to the target dose is found to be associated with improvement in the heart failure outcomes. In terms of monitoring, almost the same. We can have the renal function, and the potassium should be monitored, especially in high-risk population, as we highlighted earlier. The next agent is avapridine. Avapridine was found to has impact on reducing hospitalization and symptoms and quality of life in patients who are already receiving the optimal medical therapy, diuretics, ACE inhibitor, MRA, beta blockers. The patient who is still symptomatic with left ventricular ejection fraction is than 35%, and the most important, a resting heart rate 70 beats per minute or more. That's why the next point will be the assessment of the resting heart rate to consider initiation of the avapridine. So in those patients have to be already receiving the beta blocker at the maximally tolerated dose or a target dose. Or the patient have clear contraindication to receive beta blocker. This actually main category or group of patients will be eligible to the baseline assessment of the heart rate to consider initiating avapridine. Avapridine has no effect on the blood pressure or the myocardial contractility, and it has been associated, reported to have symptomatic bradycardia and some of the visual disturbances. Next, the old is gold, the digoxin. Digoxin actually in heart failure could be considered or added to optimal medication therapy in patients still symptomatic, moderate to severe symptoms, despite being on the optimal medication therapy. And it is good to highlight that the digoxin impact in reducing symptoms, reducing hospitalization, but not on the mortality. Digoxin as maybe very popular cardiovascular medication. It is well known that digoxin has a narrow therapeutic index, has dosing recommendation, has loading dose and maintenance dose, and. But in chronic heart failure, there is no loading dose needed, but you have to keep the serum digoxin level within a safe limit. The safe limit that minimizes the risk of toxicity is between 0.5 to 0.8 nanogram per ml. The signs of toxicity, nausea, vomiting, and visual vision changes, and so many on this track. But what is important to highlight here, that the risk of toxicity is dependent on so many overlapping or contributing factors. One of them related to the age and renal impairment, because we know the digoxin impact on the kidney. The second can decrease toxicity of digoxin, the electrolytes, especially hypokalemia, hypomagnesemia, and hypercalcemia. Hypothyroidism, one of the conditions that potentiate the digoxin toxicity, and the interacting drugs. And unfortunately, digoxin has so many drugs interacting, but right now, I just highlighted the cardiovascular medication that commonly used in arrhythmia, the amiodarone. Okay, and in this sense, there is some recommendation of reducing 50% of dosing when co-administered with amiodarone. That's all the therapeutic choices in heart failure, especially the heart failure with reduced ejection fraction. What actually the therapeutic choices in heart failure is preserved ejection fraction, formerly called diastolic heart failure. In this one, of course, there's some differences, but almost the same agents are there, but perhaps the recommendation of certain maybe medication like diuretics, and it is not that much in this category. And here also we are focusing on how we can optimize the hypertension. Hypertension can contribute from 60 to sometimes 90% of cases of heart failure with ejection fraction was underlying or contributed by hypertension. Control heart rate also can be maybe achieved by, of course, the beta blocker, non-dihydrobiidine CCB also can be used in this category of patient. And then this actually could be also one of the differences in the recommendation between the half-RAF and half-BF, the preserved ejection fraction, where the non-dihydrobiidine not that recommended to be used in heart failure with reduced ejection fraction.